Today, we're tackling a really fundamental area in medicine, adrenergic drugs. For those of you maybe studying for exams or, anyone just wanting a solid grasp on how these critical meds work, well, you're in the right place.
Absolutely. Our goal in this deep dive, using the resource Adrenergic Drug Pharmacology, uses, mechanisms, and clinical notes, is basically to pull out the key stuff, the
Yeah, awesome.
pharmacology principles, clinical uses, what you really need to watch out for.
Yeah, give you a clear, concise understanding.
Exactly.
And since this is for the KMR Advise YouTube channel, designed to go along with the document we're discussing, if you find it helpful, please do, share, subscribe, hit that bell icon for more.
Definitely helps us out.
Okay, so let's jump in. Clinical applications. The document starts right there. First up, anaphylaxis, epinephrine. It says it's the undisputed first-line treatment. Why is that? Why epinephrine?
Well, in anaphylaxis, epinephrine is, it's like a Swiss Army knife, really. It hits multiple problems at once. Its alpha-1 action causes vasoconstriction. So it squeezes the blood vessels, which brings up that dangerously low blood pressure you see.
Okay, tackles the BP drop.
Right. And then its beta-2 action causes bronchodilation. It opens up the airways, helps with the breathing difficulty.
So circulation and breathing makes sense for something so severe.
Exactly. That multi-pronged attack is why it's so vital.
Okay, moving on then. Bronchospasm, like in asthma or COPD. The document points to albuterol. What's the key there?
Albuterol is different. It's selective. A selective beta-2 agonist. So think of it targeting pretty specifically the smooth muscle in the airways.
Right.
Stimulating those beta-2 receptors makes the muscle relax. Bronchodilation. Quick relief from that wheezing and shortness of breath.
Like opening up a tight pipe, you said.
Yeah, basically lets the air flow better.
Got it. Okay, next, hypotension and shock. Here, norepinephrine is the go-to. What's its main role?
Norepinephrine, or norepi, is mainly an alpha-1 agonist. Its primary job is vasoconstriction, squeezing those vessels hard. This increases systemic vascular resistance, which, jacks up the blood pressure.
Vasopressor support.
That's the term. It's essential to counteract that really low BP in shock, helps keep blood flowing to the important organs.
And then cardiac arrest. Epinephrine shows up again. What's it doing here? Is it the same thing?
Similar, but the focus shifts a bit. In cardiac arrest, the main goal is getting blood flowing again, especially to the brain and heart. Epi's alpha effects are key here. Vasoconstriction in the periphery increases the pressure needed to push blood into the coronary and cerebral arteries.
So it helps perfusion pressure.
Exactly. While it does have beta effects that can stimulate the heart muscle itself, the alpha-driven vasoconstriction is arguably more critical for restoring circulation in that specific scenario.
Okay, getting the plumbing working again makes sense. Now, something more common. Nasal congestion. Phenylephrine is mentioned. How does that help a stuffy nose?
Phenylephrine is, again, an alpha-1 agonist.
Yeah.
When you use it as a nasal spray or drops, it constricts the small blood vessels right there in the nasal lining.
Locally.
Right, locally. Less blood flow means less swelling, less congestion in those mucous membranes, so you feel less blocked up.
Okay. And lastly, for boosting the heart, myocardial stimulation, dobutamine. What's its main effect?
Dobutamine is primarily a beta-1 agonist. Its main action is directly on the heart muscle. It increases contractility, makes the heart pump stronger, and also increases heart rate a bit. The end result is increased cardiac output.
That inotropic support you need in, say, heart failure?
Precisely, when the heart's struggling to pump effectively.
Wow, okay. So a really diverse set of uses, all based on which receptors these drugs hit. The document then lays out a classification based on those receptors. Can you walk us through that? It seems helpful.
Sure. It breaks down nicely. First, you've got your alpha-1 agonists, like phenylephrine, norepinephrine. We talked about those nasal congestion, hypotension.
Right.
Then alpha-2 agonists. Clonidine is the main example there. Beta-1 agonists, that's where dobutamine fits for stimulating the heart. Then beta-2 agonists, albuterol, and also salmeterol. Crucial for bronchodilation, asthma, COPD.
Right, albuterol for rescue, salmeterol is longer acting. We'll probably get to that.
Exactly. And finally, the non-selective ones like epinephrine hits both alpha and beta receptors. That explains a wide range of uses.
That makes sense.
And the document, helpfully for some, lists common Indian brand names too, like phenylephrine HCl, NORAD, Catapres for clonidine, Dobutrex for dobutamine, Estelin for albuterol, Ceravent for salmeterol, and just adrenaline for epinephrine. can be useful to see those names.
Yeah, definitely helpful to recognize them in practice.
Yeah.
That receptor classification really helps structure things. The keynote section then kind of reinforces the big picture. It reminds us alpha-1 agonists cause vasoconstriction, raise BP. Norepinephrine in septic shock is the classic example.
Exactly. And beta-2 agonists cause bronchodilation, albuterol and asthma, the prime example there. And it stresses, again, epinephrine's dual alpha-beta effects. That's why it's the powerhouse for anaphylaxis and cardiac arrest, where you might need both effects.
Okay, great summary. Now let's get into the weeds a bit. How do they actually work? The mechanism of action, MOA. The document breaks it down starting with receptor activation. Let's take alpha-1 first. What happens step by step?
Okay, so when an alpha-1 agonist binds to the receptor, it's like a key in a lock, this activates something called a GQ protein inside the cell.
Q, got it.
This GQ protein then turns on an enzyme, phospholipase C. Think of PLC as an amplifier. It leads to an increase in intracellular IPRs, inositol trisphosphate.
IPO.
IPRs acts as a messenger. It tells the cell to release calcium ions from storage. This flood of calcium inside the smooth muscle cell causes it to contract, vasoconstriction. And clinically, that means increased blood pressure. Phenylephrine does this.
Right. So GQ protein, MASPLC, BASC, NAP, IPSC, NTIP, APF here, calcium release, middle muscle contraction, massive constriction and METs or higher BP. Quite a cascade.
It is a well-defined pathway.
Okay. How does beta-1 activation differ then?
Beta-1 receptors use a different middleman. They're coupled to a GS protein, S for stimulatory.
Peace. Okay.
So when a beta-1 agonist like dobutamine binds, it activates Gs. Gs then stimulates a different enzyme, adenylyl cyclase. Adenylyl cyclase increases the intracellular level of cyclic AMP or KMP, another messenger.
Right. And in heart muscle cells, increased KMP leads to both increased heart rate and increased force of contraction. That's the effect we want with dobutamine in heart failure.
So Gs has protein adenylyl cyclase, KMP, increased heart rate and contractility, different pathway, different effect.
Correct.
And beta-2 receptors, they also use Gs, you said, but the outcome is relaxation, not contraction. How does that work?
That's the really interesting part. Yes, beta-2 receptors, like on airway smooth muscle, are also Gs-coupled. Activation by albuterol increases CAM binding via adenylyl cyclase, just like beta-1. But in bronchial smooth muscle, that same increase in CAM-IP triggers a cascade that leads to muscle relaxation.
So the downstream effects of KMP are tissue-specific. In the airways, it leads to relaxation, bronchodilation. That's why albuterol works for asthma.
That's a critical distinction. Same signal, different results depending on the cell type. Okay, the document then circles back to specific drugs, connecting the mechanism to the clinical effects. Let's look at epinephrine again, given its wide reach.
Right. So its alpha effects, mainly alpha-1, cause that vasoconstriction we talked about. Yeah. Raises BP, reduces swelling in mucous membranes, like in the airway during anaphylaxis. Its beta-1 effects increase cardiac output, vital in cardiac arrest, or if anaphylaxis is causing cardiovascular collapse.
Okay.
And its beta-2 effects cause bronchodilation, fighting the airway constriction. So it really covers all the bases in anaphylaxis.
A comprehensive response, yeah. And dobutamine, the note mentioned its selectivity. What's the clinical importance of that?
Yeah, dobutamine preferentially hits beta-1 receptors. This is useful because we can increase the heart's contractility, make it pump harder without causing too much of an increase in heart rate.
Which could be bad in some heart patients.
Exactly. Too much tachycardia can increase oxygen demand and worsen ischemia. So while it might tickle beta-2 or alpha-1 receptors a bit at higher doses, its main beneficial effect comes from beta-1 stimulation in the heart muscle.
Balancing act, got it. The MOA section finishes with how the body gets rid of these drugs, termination of action.
Right. The natural catecholamines, epinephrine and norepinephrine, are broken down really fast. Two main enzymes do this, MAO, monoamine oxidase, and COMT, catecholomethyltransferase. They're like the cleanup crew.
MAO and COMT.
Yeah. The breakdown products then get flushed out in the urine. Albuterol, being synthetic, is handled differently, mostly metabolized in the liver, then excreted by the kidneys.
Which explains why some of these have such short effects. Okay, that leads perfectly into pharmacokinetics. The table gives a snapshot onset, metabolism, excretion. For epinephrine, it says immediate onset IVM, metabolism by MAOTOMT, urinary excretion. Matches what you just said.
Yep, fits perfectly. Albuterol, inhaled, takes a bit longer to start working, maybe 5-15 minutes. Liver metabolism, urine excretion. Phenylpharian, if given IV, is quick, 1-3 minutes. Also MAO-COMT metabolism, urine excretion.
Okay.
And dobutamine, given IV, starts in 1 to 2 minutes. metabolized by COMT in the liver and out through the urine.
This PK data is really key for dosing, right? How fast it works, how often you need to give it, whether kidney or liver problems matter.
Absolutely vital for clinical use.
Okay, next section, clinical pearls. Some really practical nuggets here. First one, Epi's short half-life, only 2-3 minutes, means you might need repeated doses and anaphylaxis.
Crucial point, that initial dose might wear off before the reaction is fully controlled. Always be ready to give more.
Second pearl, salmeterol. It's a LABA long-acting beta-2 agonist, used for prophylaxis, preventing asthma symptoms, not for acute attack.
Right, it's for maintenance therapy, keeping the airways open over the long term, usually combined with other meds, not a rescue inhaler like albuterol.
And then there's an exam tip, everyone listening on KMAR advice, pay attention here. Adding epinephrine to local anesthetics like lidocaine causes vasoconstriction. Why do we do that?
It's a neat trick. The local vasoconstriction keeps the anesthetic concentrated right where you injected it for longer. Two benefits. One, the numbing effect lasts longer because it's not washed away into the bloodstream as quickly.
Okay.
And two, less anesthetic gets into the general circulation, so you reduce the risk of systemic side effects from the lidocaine itself.
Keeps it local, makes it last. Very useful. All right, let's switch gears to the downsides. Adverse effects. The document groups them nicely. Cardiovascular first. Hypertension with phenylephrine, tachycardia with epinephrine. Why?
It's basically too much of a good thing. Overstimulation of the receptors. Phenylephrine's strong alpha-1 effect can clamp down blood vessels too much, causing dangerous hypertension. Epinephrine's beta-1 effect can speed up the heart too much, leading to tachycardia or palpitations. Management involves counteracting these effects. Maybe vasodilators like nitroprusside for the BP or beta blockers for the heart rate.
Okay. Then respiratory. Paradoxical bronchospasm with albuterol. That sounds totally backwards.
It does, doesn't it? It's rare, but it happens.
Yeah.
Instead of relaxing the airways, the drug irritates them, causing them to constrict. The exact why isn't fully clear, maybe a hypersensitivity thing or reaction to preservatives. If it happens, you stop the albuterol immediately and try something else, like an anticholinergic.
Wow, okay. Good to know. CNS effects, anxiety, tremors with albuterol. Why does a lung drug do that?
Well, beta-2 receptors aren't only in the lungs, you also have them in skeletal muscle. Stimulating those can cause tremors.
Oh.
And the general adrenergic stimulation can sometimes just make people feel anxious, jittery, restless, usually mild, maybe need to lower the dose if it's bothersome.
Right. And finally, local effects. Necrosis with epinephrine extravasation. That sounds bad.
It is serious. Extravasation means the IV fluid leaks out of the vein into the surrounding tissue. Because epi is such a potent vasoconstrictor, alpha-1 effect, if it leaks out, it can clamp down the blood vessels in that tissue so tightly that blood flow stops.
Leading to tissue death.
Exactly. Lack of oxygen, nutrients, tissue damage, necrosis. That's why careful IV administration is crucial. If it happens, the antidote is phentolamine infiltrated into the area to block the alpha-1 effect and restore blood flow.
So handle with care. Okay, that brings us to contraindications when not to use these drugs. Some are absolute.
For epinephrine, absolutely don't use it if the patient has pre-existing tachyarrhythmias, fast, irregular heartbeats, or hypertrophic cardiomyopathy, that thickened heart muscle condition. The beta-1 stimulation could make things much worse.
Right.
And phenylephrine is an absolute no-no in severe, uncontrolled hypertension. Its alpha-1 vasoconstriction would just drive the pressure up even higher. Dangerously so.
Makes sense. And then there's a relative contraindication for albuterol. What's relative mean here?
Relative means you should generally avoid it. But maybe in specific situations, the benefit might outweigh the risk with extreme caution. Albuterol is relatively contraindicated in uncontrolled tachycardia. While it mainly hits beta-2, it can have some spillover beta-1 effects, especially at high doses, potentially speeding up an already fast heart rate. You'd have to weigh the severity of the bronchospasm against the risk to the heart.
So, a judgment call. Okay. How about interactions with other drugs?
Oh, yeah, some important ones. Epinephrine combined with certain antidepressants, TCAs, tricyclic antidepressants, or MAOIs, monoamine oxidase inhibitors is risky. Both TCAs and MAOIs can increase norepinephrine levels. Add epinephrine to that mix, and you can get a massive adrenergic surge, potentially causing a hypertensive crisis. It's a synergistic effect on alpha receptors.
Okay, definitely avoid that combo. What about beta-2 agonists and beta blockers?
Will work against each other. Beta blockers, especially non-selective ones, can block the beta-2 receptors in the lungs.
So albuterol won't work.
Right. It antagonizes the bronchodilation. Can make asthma much worse. Even selective beta-1 blockers might cause problems at higher doses. You have to be very careful using beta blockers in patients with asthma or COPD.
Good point. And dobutamine with halogenated anesthetics.
Increased risk of arrhythmias. Both dobutamine, beta-1 stimulation, and those anesthetics can affect the heart's electrical stability. Using them together requires really close cardiac monitoring.
Okay, lots to keep track of. Let's look at dosages and a few more pearls. The document gives specifics, epi doses for anaphylaxis and arrest, albuterol puffs, dobutamine infusion rates, obviously crucial for safe use.
Essential. Getting the dose right is key.
It also mentions a pediatric note again. Avoid phenylephrine nasal drops in infants. Risk of rebound congestion.
Yeah, we touched on that. The nose gets even stuffier when the drug wears off, leading to overuse, especially tricky in tiny airways.
Right. Now, toxicity. What if someone gets too much? What are the signs and what do you do?
Okay, epinephrine overdose. Think severe hypertension, dangerous arrhythmias, too much alpha and beta stimulation. The action is to give an alpha blocker, like centolamine, to lower the BP, and a beta blocker to control the heart rhythm and rate.
Counteract both effects.
Exactly, albuterol overdose. The main worries are hypokalemia, low potassium, because it drives potassium into cells and tachycardia from beta stimulation. Treatment involves giving a beta blocker, often propranolol, to slow the heart and replacing the potassium.
Okay, clear actions. There are also some really important black box warnings mentioned.
Yes, crucial safety alerts.
Yeah.
Epinephrine has one for that risk of tissue necrosis if IV extravasation occurs. Reinforces the need for careful 5E technique.
We covered that, yeah. Very important.
And salmeterol, the Elbia, has a warning about increased risk of asthma-related death if it's used without an inhaled corticosteroid, ICS.
So it must be used with an anti-inflammatory in asthma.
Absolutely. It's not a standalone treatment for asthma inflammation. It just helps keep airways open.
Yeah.
You still need the ICS to control the underlying inflammation. The document also notes that oral phenylephrine isn't actually that great for nasal congestion. Pseudoephedrine is generally better if you need an oral decongestant.
Interesting point about the oral form. Okay, and a high-yield fact to wrap up the core info. Epi is first line for anaphylaxis, and IM route is preferred over IV initially.
That's the take-home message for anaphylaxis management.
Yeah.
Intramuscular into the thigh. Rapid absorption, generally safer to start with.
Perfect. So, to pull this all together, especially for our KMR advised listeners studying for exams, there's a great final checklist in the document. It hits the highlights. MOA via alpha-beta receptors, GQG's pathways, key drugs, epi for anaphylaxis, albuterol for asthma, dobutamine for heart failure, key contraindications, epi and arrhythmias, albuterol and tachycardia, antidotes, phentolamine for alpha overdose, propranolol for beta overdose.
Right.
And those pearls, salmeterol needs an ICS, phenylephrine for nasal congestion.
That checklist is a really solid summary of the must-know facts.
So there we have it, a pretty thorough deep dive into adrenergic drugs, covering uses, mechanisms, side effects, the whole picture, all based on adrenergic drug pharmacology, uses, mechanisms, and clinical notes. Hopefully that gives you a clear, useful overview.
Yeah, understanding this stuff is just foundational. Knowing how to use these powerful drugs safely, knowing the risks, the interactions, it's absolutely essential for anyone in healthcare.
Couldn't agree more. And it may be a final thought for you to chew on. Think about how complex the body is. How might a patient's own unique situation, maybe other illnesses they have, change how they respond to these adrenergic drugs? And how does that affect the choices we make in treatment?
That's a great question. Patient variability is huge.
Definitely something to keep thinking about. Okay, for everyone watching on KMR Advise, if this deep dive was helpful, please, one more time, share it, subscribe, and hit that notification bell for more essential medical topic breakdowns. Thanks so much for joining us.